Away, Yara.
Thank you, David. Let me see if I can share a screen, and please let me know if you can see the slides.
Looks great.
Good, great. So I want to thank Dave and Chris for the opportunity to come today and present about some of the CDC resources around fall prevention. As Dave mentioned, my name is Yara Haddad. I am a pharmacist and epidemiologist on the safety promotion team at CDC in the Division of Injury Prevention. The safety promotion team primarily works on older adult fall prevention, safe mobility with aging, and aging without injury for the older adult population. Today, I'm going to highlight the STEADI initiative, or the Stopping Elderly Accident, Deaths, and Injuries initiative that was developed by CDC to promote fall prevention screening in clinical settings. The presentation will highlight the burden and risk factors for falls in older adults and how we can screen, assess, and intervene to reduce fall risk. And then we'll also cover some of the available tools and resources as part of STEADI. Starting with the burden, traditionally, unintentional injuries have been the 7th leading cause of death among older adults, and falls are the #1 cause of those unintentional injuries in that population. Every second of every day an older adult falls. This adds up to approximately 36 million falls every year. Of those who fall, more than 8 million older adults are injured. And these falls and fall injuries lead to about 3 million emergency department visits, more than 950,000 hospitalizations, and more than 32,000 deaths each year. Although falls are common, older patients might not tell their healthcare providers about their falls. And there are several reasons for this. They first might think that they are a normal part of aging, falls are a normal part of aging, and that there's nothing that can be done to prevent them. They also may fear that talking about their and threaten their independence. And also older patients may be unaware of the common risk factors that increase their risk of falling. This is especially true for older adults that are on psychoactive medications or medications that are linked to falls, and that they've been taking these medications for a long time. Many older adults may not identify that these medications can increase the risk of falls. All right, this study found that over 80% of older adults taking psychoactive medications reported that they had not spoken to a healthcare provider about the risk of falls from the medications. Though on a positive note, this same study reported that older adults are willing to discuss and change medications to reduce the risk if they are able to identify those risks and if their healthcare provider recommends a change. From a healthcare provider view, studies show that healthcare providers also face some barriers to addressing falls with their older patients. This can be due to competing health priorities in the patient, lack of time during visits or in clinical settings, limited fall prevention knowledge, and potentially limited reimbursement strategies as well for fall prevention efforts. But it is important to prioritize fall prevention because the consequences of falls can be very serious. Falls result in debilitating injuries such as hip fractures, traumatic brain injuries, loss of independence, and even death. In the United States, the fall death rates have increased about 30% from 2009 to 2018. This is after adjusting for the aging population. Falls also pose a significant economic burden. I'll note that these estimates that you see on the screen are for non-fatal falls, but injuries from falls that result in emergency department visits or hospitalizations or nursing home and rehab facility placements all contribute to this medical spending for falls. Overall, in the United States, $50 billion is spent for medical care due to falls every year. And the publicly funded programs like Medicare and Medicaid pay for more than 75% of these costs. Falls are a growing burden. The number of falls and fall injuries are expected to rise if more fall prevention efforts are not put into place now. By the year 2030, 1 in 5 Americans will be ages 65 and older, and we can anticipate about 52 million falls and 12 million fall injuries in that year. Falls are associated with risk factors, and as you can see, the modifiable risk factors make up the majority of the risk factors in older adults. Those include difficulties with gait and balance, use of medications with fall-related side effects, or use of polypharmacy or multiple medications, home hazards, orthostatic hypotension, problems with vision, problems with feet or improper footwear, vitamin D deficiency, and comorbidities like depression, incontinence, or dementia. Non-modifiable fall risk factors are those that we cannot adjust. Those include advancing age, female sex. Women are known to be more likely to fall and be injured from a fall compared to men. But when men fall, they tend to have more severe injuries from their fall and have higher death rates compared to women. For race and ethnicity, we found that more American Indian and Alaskan Natives fall compared to the other ethnicities. But overall, the risk of falling increases as the number of risk factors increase, and we can certainly target the modifiable fall risk factors to help reduce the risk of falls. Again, falls can be prevented by targeting modifiable risk factors, and the Stopping Elderly Accident Deaths and Injuries Initiative, or STEADI for short, was developed by CDC based on the American and British Geriatric Society's clinical practice guidelines for fall prevention. STEADI offers healthcare providers tools and resources to manage fall risk in clinical practice settings. And there are 3 main components to STEADI: screen patients for fall risk, assess at-risk patients for modifiable fall risk factors, and then intervene to reduce the identified risk using effective clinical strategies. I've previously mentioned some of the barriers that healthcare providers are faced around prioritizing fall prevention in practice, such as lack of time or lack of available resources. But there are ways to integrate fall prevention activities into existing clinical workflow. One of our newer resources from CDC is the Coordinated Care Plan to Prevent Older Adult Falls. This guide provides suggestions on ways to implement a fall prevention program based on the STEADI initiative into a health system by using, for example, existing incentives to screen and assess for fall risk, like the Welcome to Medicare visit or the annual Medicare wellness visit. There are also examples of how to adapt STEADI tools to fit priorities and clinical workflow for each individual health system. We'll be looking closer at some of the examples that have adapted and implemented STEADI into their practices. These are 2 of them: Oregon Health and Science University and the United Health Services hospitals. It is encouraging to know that STEADI has been successfully integrated in several practices with positive results. The experiences from these 2 programs have helped inform the 12 steps described in the CDC Coordinated Care Plan that I just shared on the previous slide. For example, before implementing STEADI, providers at United Health Services hospitals in New York did not routinely screen for falls, but within a year of implementation, they screened 79% of their older patients. And implementing STEADI in these primary care settings led to lower fall-related hospitalizations. So overall, integrating STEADI into clinical practice can help prevent hospitalizations due to falls, reduce healthcare costs, and then improve the lives and independence of older patients by preventing injury or promoting aging without injury. Okay, next I want to cover another STEADI resource that could help clinicians with fall prevention efforts. This is the STEADI algorithm, which highlights steps of the screening, assessing, and intervening to reduce fall risk. Though this figure is kind of difficult to read, I will highlight portions of the STEADI algorithm in the next few slides. Okay, the first component of the algorithm is screening. For all patients ages 65 and over, it is recommended to screen for fall risk at least annually or any time that a patient presents with an acute fall. There are tools available to screen for fall risk. The STEADI initiative includes 2 tools, the 3 key questions and the Stay Independent Questionnaire. Okay, so starting with the 3 key questions, they include, have you fallen in the past year? Do you feel unsteady when standing or walking? Or do you worry about falling? If the older adult answers yes to any of these questions, then they are screened at risk for a fall. And then the recommended next step is to conduct a fall risk assessment to identify modifiable risk factors. If the older adult answers no to all questions, the next step is to screen again in the future and provide other strategies to reduce future risk, like staying active or participating in group exercises to maintain gait and balance. The second way to screen for fall risk is using the Stay Independent Questionnaire. This screener has 12 questions that older adults can complete on their own. Maybe if they're waiting to be seen by their primary care provider, this could be provided to the patient while they wait. This offers insights into the patient's specific fall risk factors. An older adult is considered at risk if they score 4 or more on this fall screener. Again, if the older adult scores 4 or more on the Stay Independent Questionnaire, they are screened at risk for falls. And the next step is to conduct a fall risk assessment to identify fall risk factors. If they score less than 4, but report a fall in the previous year, they are still considered at risk for fall and should undergo fall risk assessments. If they score less than 4 with no history of a previous fall, they are screened not at risk and recommended for future screening. The second step in the algorithm is to assess, to identify modifiable fall risk factors. A good start is to conduct a fall history assessment by asking how many times they've fallen, if they had any specific symptoms that was associated with the fall, or maybe the time and location of the fall. These questions can help identify some of the extrinsic factors, such as environment or home hazards, or intrinsic factors like orthostatic hypotension. Many older adults have multiple fall risk factors, and so it is recommended to conduct as many of these assessments as feasible in the clinical setting or for the patient. There are assessments for gait and balance disorders, medication review, home evaluations for home hazards, measuring orthostatic blood pressure, for vision, for feet, vitamin D intake, and comorbidities, identifying comorbidities. And then the final step of the algorithm is to intervene. Once the modifiable fall risk factors are identified, you would work with the patient to develop a tailored fall prevention care plan that includes evidence-based interventions. In the next few slides, I'll go over some examples to highlight the components of STEADI from screen to intervene. So this would follow a patient that completes the 12-item questionnaire from the Stay Independent brochures and scores above a 4. And so they are screened at risk for fall. To assess for gait, strength, and balance deficits, we can conduct assessments such as the timed up and go, tug test, the 30-second chair stand, the 4-stage balance test. And these tests can help assess mobility, leg strength, and balance. If deficits are identified, the intervention can be referral to physical therapy or other evidence-based exercise, such as Tai Chi, or maybe a fall prevention program, such as stepping on. And then throughout the next slides, you'll see this bottom section called STEADI Resource. This will highlight the available resources on our webpage that I discuss on each of the slides. There's references and links at the end of the presentation as well. This is the medication example. Assessment would be conducting a comprehensive medication review to identify polypharmacy, which is typically described as 5 or more medications, or identify medications that increase the fall risk, such as psychoactive medications or antihypertensive medications. And then interventions include medication changes and could range from deprescribing or some form of the stop, switch, or reduce actions to modify the medications. For home hazards, there is a check for safety brochure to help guide the conversation about potential hazards in the home. Referring to occupational therapy is a great option if it is available. They can help with any home modifications as needed. The check for safety brochure also offers tips to improve home safety, such as keeping paths clear of clutter, removing throw rugs in the home, improving lighting, installing handrails or on stairs, or installing grab bars near in the bathrooms or near the showers. For orthostatic hypotension, this is another modifiable fall risk factor. Interventions can include adjusting medications if they are contributing to the drop in blood pressure with positional change, or treating any underlying causes. General recommendations can be provided to the patient here, such as increasing hydration, foot pumping before standing, or instructing the patient to stand slowly and waiting to walk to prevent any kind of syncope or fainting episode that happens when we stand too fast, when we stand up too fast. Again, there are handouts on measuring orthostatic hypotension and then educational information for the patient about managing postural hypertension. For vision impairment, assess by asking the patient about vision problems or assessing visual acuity, and then ask about the use of corrective lenses or glasses when walking outdoors. Some interventions include referral to ophthalmology or optometry for additional problem identification with vision, and then recommending single distance lenses for walking outside instead of bifocals. Feet and footwear, again, checking for deformities, deficits in sensation or pain in the feet, assessing inappropriate footwear, such as wearing heels or flip-flops, and then the intervention would be referring to podiatry or counseling on proper feet care and footwear. For vitamin D deficiency, assessment can be done by lab work to measure vitamin D levels, or it could be by asking the patient about dietary intake. If deficiency is identified, the intervention is increasing dietary intake or daily supplement of vitamin D, depending on the patient case. And then fall risk assessment also includes identifying if the patient has comorbidities such as depression, which is highly linked to increased risk of falls, dementia, incontinence, osteoporosis. And the intervention here is optimized treatment of the condition to reduce risk, and it will be very patient specific depending on the comorbidity and the patient status. After the 3 key components of STEADI, the screen, assess, and intervene, a follow-up with the patients and their care providers can help enhance the plan of care. The STEADI resources talking with patients about fall prevention and family caregiver, protect your loved ones from falling. Those brochures can help communicate with the patients and their families the importance of implementing and adhering to their fall prevention plan. Okay, so just checking the time. When STEADI was developed, it was intended for primary care settings, like outpatient clinics and ambulatory care settings. And the coordinated care plan that I highlighted previously covers implementation of STEADI in an outpatient clinic setting. But since then, STEADI has expanded beyond primary care. With hospitalization, there is an increased risk of fall during hospitalization, and also an increased risk of falls after hospital discharge, because older adults are more likely to experience a community fall in the first month after their hospital stay. This could be due to decreased mobility during their hospital stay, either from being confined to their bed or a hospital room during their stay in the hospital, or some form of increase in functional decline during hospitalization. But our newest guide, newest till now, is the CDC STEADI resource, Best Practices for Developing an Inpatient Program to Prevent Older Adult Falls After Discharge. This is a best practices guide for implementing STEADI in the inpatient setting to reduce falls in the hospital setting and after discharge, promote better collaboration with primary care providers for both post-discharge care, and then identify and manage fall risk factors. Again, the guide is available on our webpage, and it's highlighted down here in the STEADI resource section. The guide refers to available community fall prevention resources that can complement existing health system programs for specific interventions. Community fall prevention resources are listed here with their web pages, linked web pages if they are available, but those include Administration for Community Living, local area agencies on aging, local YMCAs, National Council on Aging, and so on. There is a detailed listing in the guide as well. Examples of community resources for fall prevention efforts like Stepping On. There are fall prevention classes through local area agency on aging. Tai Chi classes that may be offered with local YMCAs. There are also wellness programs that may be available through health insurance providers like the Silver Sneakers or the Silver and Fit programs through Medicare Advantage. Outpatient physical therapy, occupational therapy, community pharmacists or community pharmacies that can help with medication management, community resources for appropriate footwear, and then community resources for affordable corrective eyewear. Okay, another expansion beyond primary care is the community pharmacy STEADI RX or STEADIer program. STEADI RX was designed to improve collaboration between community pharmacists and healthcare providers to screen older adults for fall risk at the pharmacy, assess for fall risk factors associated with medications by completing a comprehensive medication review by the pharmacist, in the pharmacy, and then share information with the patient and provider and intervene to reduce the risk by adjusting medications when warranted or providing education to manage side effects if the medication cannot be changed or stopped. And then similar to the STEADI algorithm, STEADI RX also has an algorithm that follows the 3 steps of screen, assess, and intervene. So screen for fall risk, assess for medications that increase the risk of falls, and intervene by coordinating care between pharmacy and primary care providers for any medication changes. So that will bring me to the end of the main portion of the presentation. For the next few slides, I'm going to quickly go through some of the available resources. On our webpage, cdc.gov/STEADI, you will find all of the resources and tools that I shared with you, plus additional training for different provider types. We have provider types, primary care providers, nurses, pharmacists, and physical therapists. There's training on our webpage on there. You can also hear about success stories of other providers that have implemented STEADI into their clinical settings. Dave, do you want me to go through some of the resources, or how are we doing with time?
I think we're doing okay. Why don't you spend a couple minutes here just talking about what you have? Sure.
So these are the resources that I highlighted throughout the presentation. This is, the first one is the coordinated care plan, which was our initial one of how to implement STEADI in a primary care clinical setting. Then we have the evaluation guide for older adult clinical fall prevention program. The next slide is the best practices for developing an inpatient program to prevent falls, and the STEADI RX, which is the community guide, the guide for community pharmacists, excuse me. These are the STEADI assessment handouts, the timed up and go, the 4-stage balance test, the 30-second chair stand, and how to measure orthostatic blood pressure. So we have fact sheets for these on our webpage, but we also have video graphics of how to conduct these assessments as well on the cdc.gov webpage. Some of our medication resources, like the medications linked to false fact sheets and the safe medication review framework of how to identify and how to target medication management and adjust medications to reduce risk. There's also one for how to talk to your patients about fall prevention, and this is targeted for healthcare providers. These are educational material that we have for the patients that can be ordered or printed out off of our webpage. We have the Stay Independent brochure, the Check for Safety, which goes through home modifications or home assessments and then home modifications, postural hypotension, and there's one specifically for family and caregivers, and what you can do to prevent falls. And then the last two are practice fall prevention wall chart, which goes through the different tests and tasks and what is needed. And then the algorithm that I highlighted earlier, this is the front page of the algorithm, but this is also available on our webpage. And that takes me to the end. I want to thank you again for the opportunity to highlight some of our resources. You'll find more information on cdc.gov/STEADI. I also want to take an opportunity, a quick 30-second, to highlight our new Aging Without Injury communications campaign that just launched in May. You can find more information about it on cdc.gov/stillgoingstrong. So there was specific targets in Wisconsin because Wisconsin had one of the higher death rates from falls in the country. And I included my contact information here. If you have any additional questions, you can reach out to me. But Dave, I'm sorry, I keep calling you David. I will turn it back over to you.
And I'll go by Dave or David or whatever else you call me. All right, that's terrific. So one of the things that I'm struck with here is just how much there is, right? All these different solutions. And I don't know if we can get the view back to see everybody. There is a lot here. There's a lot here that we can do. There's a tremendous need. We're spending $800 million in this state annually, and that's old data, so it's probably much more. And there's a whole lot of things that we need to be doing together, both in the clinical setting and in our community-based organization settings, the ADRCs and so forth. In addition, we're in the middle of a global pandemic, a persistent pandemic, in which people are staying away from care that they need, and some of this treatment is getting even harder. I want to hear from our discussants a little bit about how they work in this setting and how they take some of these into their actual practice. And we're going to start with Dr. Gerald Pankratz. Dr. Gerald Pankratz with the UW School of Medicine and Public Health. I want to hear your thoughts about this, generally speaking, and particularly how you work it in your own clinical setting. And then in addition, if COVID has given us any more pauses and things to work on here as well. So take it away, Dr. Pankratz.
Sure, and thank you, David and Chris, for inviting me here. I apologize about my voice. I'm dealing with some bronchitis I picked up from my son who goes to daycare. So if I have a coughing jag, I do apologize. So I will thank you as well for that very enlightening presentation on the CDC and the STEADI initiative. So I'm a primary care geriatrician, and I also run the interdisciplinary falls clinic at our 2 sites here in Madison. So I'm in the unique position where I can see kind of things from both ends. What we would do in the primary care setting, especially with a new patient, is that we would see during the rooming process, our medical assistant would give them the Staying Independent questionnaire, and if they screen negative, that's great. We'll give them some advice about how to maintain their balance going forward. But of course, if they screen positive from there, we would initiate some additional assessments. In the primary care setting, of course, we're very short on time. So I have the advantage where I can just say, all right, I have a falls clinic, we can do this more comprehensively there. But essentially a primary care provider could open up a smart set and then you can order labs, they can consult with us, or they can go to PT, podiatry, ophthalmology, whatever they think is applicable for the individual who screen positive for falls issues. And then on the interdisciplinary falls clinic, which is run by myself as a geriatrician, a physical therapist who's trained in balance disorders, and a social worker, and we work as a team. We try to do everything all together during normal times. During the COVID pandemic, we do a little bit telephonically before the appointment, especially the social worker can do some of their work in that fashion. And we're essentially just, as Yara mentioned, we're looking at those modifiable risk factors that could really, move the needle as far as risk of future falls or just preventing falls for the individual. I will look at medications. I will look at other comorbidities, as she mentioned, depression, osteoporosis, frailty, neuropathy, especially with a diabetic neuropathy. And we try our best to be very comprehensive in terms of medical evaluation. Our therapists follow a standard rubric looking at their static balance, their dynamic balance, and can often make good recommendations as far as assistive devices, if they came in with a specific type of cane or walker. And in general, our social worker is going to be looking at their home setting, what kind of support programs they're working with. And if it hasn't been done in the recent past, we'll also offer to do a cognitive screen, as we do know that dementia is a very big risk factor for balance impairment and falls. And we often do detect some problems in that regard, and at the very least we can make the patient or their family aware that there may be a problem developing that could be looked at a bit more carefully at one of our memory clinics. And then from there, we typically are going to have an engagement with physical therapy longitudinally. I know that they're doing some things virtually, but in general, we do feel that it's warranted to get people into the physical therapy clinics. And then I would typically see the patient back. We're adding in some nurse practitioners now as our clinic's expanding, and usually about 4 to 6 months to reassess if they had any falls in that interval, and seeing if there's been any roadblocks that they've appreciated as they've been working on their balance. And in regards to COVID, Dave, yeah, it has made things worse, unfortunately. Older adults were one of the highest risk groups that we've known about largely from the beginning here. And they've been quarantined, especially at our ALFs and nursing homes. And it's been really hard for a lot of them to do very much physically, especially with other individuals, which we do know is a help for many of us as far as doing things in a social kind of environment. And of course, there's been an increase in this state in drinking alcohol as well. And we do know that that's adverse as far as a balance risk as well. So hopefully it'll get better with time, but it's been particularly tough on our patients.
That's terrific. I'm going to move on so we can get all of our speakers in here as well and make sure we do that. Then maybe we'll have some time for some questions after that. Dr. Allison Botrup, with eye care, how does this work into the work that you've done? Speak generally, and then just one of the thoughts that I keep having is how in a clinical setting we do all of this with everything else that you have to do as well. That's something that keeps in my mind, but go ahead, Allison.
Right, sure. So thank you again for having me. My name's Allison. I'm a nurse practitioner with Eye Care. Just a little bit of background, Eye Care is a managed care organization, and our primary population is persons eligible for Wisconsin Medicaid. I work specifically in the Family Care Partnership Program. And in our Family Care Partnership Program, we work as an interdisciplinary team. We have nurse practitioners, nurses, and care managers, and we all work together to assist with care coordination for our members. And as a nurse practitioner, my primary role is in our hospital readmission prevention program, which, as Yara mentioned, is a particularly high risk time for falls to happen. And each member of our IDT team or interdisciplinary team is educated on the importance of falls assessment, prevention, and education for our members. And we assess for falls and falls risks pretty much every member interaction that we have. Our falls risk assessment tool, which we will discuss kind of more in the next webinar, is based on the CDC STEADI algorithm, which Yara reviewed very well. In addition to this evidence-based screening tool, we work really closely with our members to identify fall prevention interventions that are very unique to them based on the risk factors that we identify through the assessment. And we often include a variety of the interventions that Yara reviewed. And then in addition to fitting falls risk assessment and education into our visits, as we know, as it was already discussed, it can be very hard to cover those in general medical visits, I think, that members have. So we have a really great, unique opportunity to always assess for falls risks whenever we're talking with our members, which is very often. We talk to our members a minimum of once a month. So we are able to provide very high touch care and kind of help fill that gap between when they see their other medical providers to kind of continue that discussion about falls. Have you had a fall? How are your interventions working? And that helps us kind of identify additional resources that might be needed to help keep them safe in the environment. So it's a lot to accomplish, but I think that iCare has a great role in being able to kind of fill that gap in between following up with other medical providers.
Okay. Well, thank you. And we'll look forward to talking with you more today, but also Allison is coming back with us within 2 weeks to really talk about the details of how that works. So if you want to hear about the details of in the clinical setting, but also in the handoff to other community-based organizations on referral, we're going to really focus on that in 2 weeks. Let's turn back over to Christine Henson. Christine, your thoughts on this and how it works within Inclusa.
Hi, Dave. Thanks for having us today. I also work for a managed healthcare organization that's Medicaid driven. I'm a registered nurse on the western part of the state with Inclusa. And I have a mixed caseload of frail elderly, developmentally delayed, and physical disabled members. So I can see members that are anywhere from 18 to I have a 100-year-old on my caseload. So we also use a very comprehensive fall risk assessment that we do upon enrollment to our program. And then every 6 months when we meet with the member and his or her circle of support, and we work on the member-centered plan. In addition, we also do a minimum of once a month phone contacts to our members in which we always address falls, have you had a fall? And we have the unique perspective of that we go into the member's home and community. And that looks very different for all of our members. It could be their own home, a supportive home, adult family home, CBRF, a nursing home. So then we work with what their home environment looks like, what are their risks, and then we're able to put those interventions in place. So if we identify that somebody needs a particular part of a equipment or durable medical equipment, we can go forward with purchasing that, putting that in place, and making sure that that helps meet their health and safety needs. And I also work as an interdisciplinary team. All of our members have a community resource coordinator and a health and wellness coordinator, in addition to our circle of support for durable medical, transportation, and all the other important people that help keep us moving forward.
Well, that's fantastic. And thank you for joining us. And again, we'll have Christine in 2 weeks to go into the details on that. I want to open this up to some questions that we might have. And the first question is always the hardest, so I'll start us out. Yara talked about only 1/2 of people who have fallen mentioning that or asking their providers about that, about their fall. Part of this is because they see falls as normal. How do you start the conversation with somebody who might be hesitant to talk about it? Some of the things that I've heard is people do not want to talk about falls because they're at risk of losing their independence, right? If I'm in danger at my home, gosh, I better keep that fall quiet. There may be just a little bit of hesitancy and nerves, and I think this might be particularly important among some of the Medicaid populations that are out there who may be especially vulnerable, especially with diverse groups who may especially with our Native American population, we see the highest rate of falls. How do you start that conversation? How do you get people into this? Once you decide that this is going to be a priority and you can do the screening, how do you start that conversation and allay their worries? Who would like to respond to that? Christine, you're big on you're the one on my screen right now. So why don't I look to you to think about that? You've had those conversations. How do they go?
Absolutely. So it's in the approach. You're right. The word fall has connotations with it that maybe members won't be as forthcoming. So sometimes we refer to them as near misses. You know, when's the last time you had a near miss? Sometimes I don't use it as a yes or no question. I don't say, have you had a fall? Sometimes we word it as, when was your last fall or your last near miss? Or people with neuromuscular disorders where they generally just have periods of weakness that they can't anticipate. When did you lower yourself down? When did you have an unsuccessful transfer? So even though we're not using the word fall, we're still anticipating that there are that potential there for the fall with members. You just don't want to be judgmental. And I always say, I'm not going to tell you you can't do that activity. We're just going to find a safer way to do it.
I love that idea of when was your last near fall? Because I had a near fall, they might be more willing to talk about it. Or just when was your last fall? Don't give them a chance to say, oh, I should hide it. Just assume that it's a normal thing that can happen, even though it's not normal and we can prevent it. But it is something they can just talk about. Other folks on that, about how they broach the subject.
Can I speak?
Sure, come on in.
I'm Elise. I am a case manager RN in Milwaukee. And what I tend to do is get to know the client and find out what their hobbies are. And around the hobbies, I always make I ask a question like, oh, wow, I bet that's, a really, really good hobby. But have you had an almost fall from doing that hobby? So sometimes clients will admit that and sometimes they don't. So just finding out, what their likes and dislikes are and hobbies and work around those questions, kind of like how the other nurse was suggesting.
And now I can understand many of the seemingly unrelated questions that I get asked at my primary care visits, and that they're all lead-ins to a bigger strategy. I know that we have an additional question here that I've seen. Anybody else want to comment on this sort of hesitancy to have the discussion?
This is Lisa Kanan from Kenosha County, and we are just starting our new falls prevention and intervention program. And one of the things that I'm doing when I'm following up with people who have recently had a call is I will say to them, hi, introduce myself. I understand you recently had a fall. Kenosha County's ADRC has a new program that can help you remain independent and safe in your home. And it seems like people are responding to that because, as someone said earlier, they don't want to leave their home. So if I am addressing the fact that this program will help them to remain independent in their home, it seems like they're more open right from the get-go to start talking with me.
That makes a lot of sense, Lisa. Thank you. Yeah, putting, what are the incentives? What are the goals of the person in front of you, and helping them see how that lines up? I've got two questions here. The first one coming in from Susan Abel. Can Yara, Dr. Pancras, anybody, can you give some specific examples of how cognitive decline and impairments put someone at greater risk of falls? So brain health is important to a lot of us. What happens with these issues and how do they contribute to greater risk of falling?
Sure, I can take that one. So neurocognitive disorders, dementias, are going to be associated with a number of different risk factors, including medications that are often used to treat them or the behaviors associated with them. But there's also going to be some changes as far as reaction time with dementia, and also that there's going to be oftentimes impairments in the patient's judgment. So they might be putting themselves into higher risk situations. If they're in an assisted living, they might be neglecting to hit the call light and trying to get up to the bathroom on their own. They're forgetting their assistive device because of their underlying cognitive impairment, which is going to put them at a much higher risk of falls or in injurious falls as well.
That's terrific. Thank you. Chris, I see that you nudged me that you had a question. Why don't you jump in here, Chris?
Yes, great, thank you. Just curious about, you talked a little bit about hesitancy on the part of older adults in terms of being willing to talk about having had a fall or a near miss. Can you talk a little bit about some of the challenges around once someone has been identified at high falls risk, getting them to accept or embrace the idea of an intervention? And I'm making that assumption that that can be challenging in some cases to get people to want to follow through with an intervention.
Who would like to jump in on that?
So I'll just take a quick stab at it from like the epidemiologist side, not the clinical side. Excuse me, the studies that we've conducted do show that patients are willing to make changes and modify their medications or join into some kind of fall prevention exercise program if recommended by their healthcare provider. There's a lot of research out there that patients do trust their healthcare providers, trust their judgment, trust their recommendations. So, that's from the research side of it, that it is very important for the healthcare provider to lead that conversation into identifying the risk and then making recommendations to reduce that risk. Patients do receive that information as something that they are willing to take on, but I will leave it up to others that are in actual clinical practice to provide some input.
Yeah, so the question is, you've screened somebody, you have recommended an intervention. Perhaps you've recommended stepping on as a multifactorial approach. It looks at a lot of these issues that are out there. How else do you get people to follow up? I know I often have conversations, I'll be honest, with my doctor, and I'm really good for a little while about following up on those pieces. More honest, I took the test, the larger point, I scored a 4, so I am at risk for falls. I'm only 52 years, so that was surprising. What do you do with somebody like me who is at a 4, maybe a 5, and you need to get them to think about this seriously? And what do you do with somebody with greater needs to make sure that they follow up? Allison, Christine, do you have any thoughts on this?
Sure, I can address the issue of approaching somebody with a need to change a pattern of behavior. And I'll just use a walker as an example. It's, it's one of those tools that really helps steady people, but they're not always ready to embrace it because it labels them as disabled or weak or elderly. And so sometimes I have a gentleman right now in memory care, and we refer to it as his double cane. We don't call it a walker for whatever reason. He likes the idea that he's using 2 canes to walk. Sometimes you can approach it to the fact that, hey, we could put a little bag on this walker. You can carry your bottle of water, your cell phone, your PERS line or something like that. And then they see it more as something that's adaptable and it's of use to them if they can carry things. They don't necessarily see it as, oh, it's going to help steady my gait and it's going to be there for if I'm feeling weak or faint. So sometimes just kind of incorporating what's important to them. Once somebody becomes acclimated to a piece of equipment, a cane, a U-bar, a walker, they usually embrace it, and you rarely see them without it.
I'll also add to that.
Yes.
I just think in general, I think the biggest takeaway from everything that everyone's sharing is that whether it's patient-centered or member-centered, it's really taking the time to understand what motivates somebody so that you can work together as a team to really help promote, what's best for them, what's in their best interest. And sometimes when we just tell people what to do, that's not always received well. So really working together with each individual to kind of help explain why we think it's important and kind of understand where they're coming from as well.
Well, that's really helpful. And we'll talk more in 2 weeks about how we make that connection. especially how do you make a connection to somebody to say, hey, I want you to spend 7 weeks on an intensive 2-hour-a-week program to really look at all of your needs. How do we get people, how do we motivate them around that? But Mary Lobby has asked a question here in our chat box. And Mary is always good about making things, making us think about things on a statewide or even global perspective of how do we tackle this. Mary asks, given the size of this problem in Wisconsin, again, we are dead last or we are first in deadly falls, however you want to think about it. What do each of the speakers wish we could do better in this state? And that doesn't have to be specifically at UW Health or iCare or at Inclusa, but it can really be thinking about what we do with our state government, what we do together, how nonprofits come together, how counties come together. What would you like to see? How do we get from number 1 to number 50?
Yeah, I would just say as a clinician, making sure that I'm aware of the avenues that are going to be effective at reducing someone's risk. Of course, our services at the Interdisciplinary Falls Clinic, and of course, the increasing the funding would be my plea to the state as far as getting community-based programs like Stepping On more rolled out to the entirety of the state.
Okay, from your lips to the governor's ears, Dr. Pankratz. Let's quote him on that. Because I know that we have many community organizations ready to do this and do this work. Yara, you're looking at us, but behind you, you have a map of the country. So I like to think of you as some kind of global headquarters at the CDC, thinking here. We are in a terrible place here in Wisconsin. We are in crises within crises, right? So you have the falls crisis, you have the pandemic, you have what the pandemic has done to the workforce and the ability of community-based organizations to respond quickly. What do we do, Yara? You've given us some great advice from a clinical setting, and I think we're going to listen to that, but what would you think that the state should do?
So I just want to kind of highlight that Wisconsin is the leading state in deaths, but it is not the leading state in injuries or in costs. So, we can't tell from the data why that is. If, more injuries, more falls are injurious that they lead to death versus, just an injury that you're able to survive and then accumulate lots of spending. But I will say that with the pandemic, there's also been a lot of physical deterioration in older adults, that they have been homebound for a long time. So the gait and balance disorders are going to be more evident in those patients that maybe have been doing telemedicine for the past 2 years, for the past 18 months or so, or that have stopped being able to join community-based exercise programs. So I think, it's something that the major target, I think, would be the gait and balance disorders, addressing those risks, those deficiencies in this population that maybe has suffered more than other populations. In your state, if there's been lots of lockdowns or stay-at-home orders during this time that has caused older adults to stay at home, or even prioritization of care in health systems, so that, if you're overloaded with COVID, have you been delaying other primary care in these older patients? So it's not an easy response, went around, but addressing these patients now, their needs now, addressing their physical concerns, physical deterioration through the pandemic, and really concentrating in building that gait and balance, strength and balance in older patients to help reduce some of the falls. And I'm sure, Dr. Pankratz, you can speak to some of the cognitive decline that's been kind of associated with the social isolation, the depression, the all of that's happening alongside with the pandemic. So multifactorial, definitely lots of different interventions and resources are going to be needed to get older adults back into baseline.
Thank you, Yara. Now, Christina and Allison, you're going to be back with us in 2 weeks, so you can maybe give us a hint about what you'll be talking about. But really, right now, you can talk a little bit about what you're going to do with us in 2 weeks, but also, what would be your wishes for the state?
I
We
just
could
want to
get.
make sure that I'm printing off the correct thing.
All right,
it
if you
should be
are
the
if you are out there, if you could please
most
mute
recent
your
list,
microphones.
And that's usually
August
the date,
25th.
right? Whoops, I'm sorry, yeah. That's usually
Hello,
the
if you
date,
wouldn't
so
mind
that
muting,
corresponds with the date.
go ahead and talk over Christine
sorry.
and Allison.
I would just say collaboration and knowing your resources on not only a state level, but a community level too. I mean, we've got a wide variety of very densely populated counties and very widely sparse rural areas too, where resources may not be as readily available. So collaboration, having those discussions and education is just going to be premier in getting the word out and making fall prevention a priority with everyone, both inpatient, clinic, and community.
Thank you, Christine. Allison, I'm going to let you get any last words before I get my last words in.
I would agree with that. I think a large thing is accessibility. I think a lot of our members, some of our trainings have been adapted to be online, but a lot of our members don't really have solid internet connections. So even that is not necessarily improved accessibility for things like this. So just continued growth and expansion of resources, I think, in the community is needed.
Well, this has been a great conversation and a great level setting for our next conversation. So we'll have Christine and Allison back with us in 2 weeks to get into the real details of how this works in a clinical setting. We also want to hear from our community-based organizations. Again, I talked about we are in a crisis, right? There's so much going on right now, and we can't let falls be ignored or forgotten in this. I really appreciate the comments about greater funding for these issues as well, and we hope to be a part of making that happen. Yara, Gerald, Allison, Christine, thank you so much for your time today. We look forward to talking more about this, and we're going to roll our sleeves up in the next couple of weeks and have some more in-depth conversations. Thank you so much.
Thank you. Bye.
Bye, everyone.
Thank you.